I am Mark Fendrick, a practicing primary care physician and a professor at the University of Michigan. Go Blue. Mr. Chairman, I applaud you for holding this hearing because access to quality health care and containing Medicare costs are among the most pressing issues for our national well-being and economic security. Moving Medicare Advantage from volume-driven to a value-based program requires a change in both how we pay for care and how we engage consumers to seek care. Yet, before today's hearing, little attention has been directed to how we can alter beneficiary behavior to make MA more effective and efficient. Today, I urge you to support the bipartisan effort to allow MA plans across the country to incorporate value-based insurance design to help members become better health care consumers. I could tell you with great confidence that my Medicare patients could care less how much the federal government spends on health care, but they do care deeply about the amount they have to pay out of pocket to get the care they need. With rare exception, MA plans implement cost sharing in a one-size-fits-all way, in that each beneficiary is charged the same amount for every doctor visit, every diagnostic test, and prescription drug. People ask me all the time whether the amount of cost sharing faced by MA members is too high or too low. The answer, as every clinician knows, is it depends. But asking MA members to pay more for all services, despite clear differences in clinical value, results in decreases in the use of essential care, the care I beg my patients to do. And this cost-related non-adherence negatively impacts our most vulnerable patient populations. So I see this blunt one-size-fits-all approach as penny-wise and pound-foolish. Does it make sense to you, Mr. Chairman, that my MA patients pay the same co-payment to see a cardiologist after a heart attack as to see a dermatologist for mild acne, or pay the same prescription drug copayment for a life-saving drug that treats diabetes, cancer, or depression as one that makes toenail fungus go away? Realizing that MA beneficiaries use too little high-value care and too much low-value care, I endorse a clinically nuanced cost-sharing approach as a potential solution. Clinically nuanced value-based insurance designs set consumer cost-sharing levels to encourage the use of high-value services and providers and discourage the use of low-value care. For the record, I support high cost-sharing levels, but only for those services that do not make MA beneficiaries any healthier. Led by the private sector, VBID is implemented by hundreds of public and private employers, several states, and will soon be incorporated into the TRICARE program. The integration of VBID into MA has garnered broad multi-stakeholder and rare bipartisan support. I would like to acknowledge subcommittee members Diane Black and Earl Blumenauer, whose bipartisan leadership on this issue led to the 2015 announcement of the MA VBID model test, a 5-year program that allows designated plans, now in 7 states, to reduce cost sharing for specific services and providers, but only for those beneficiaries with specified chronic conditions. In January of this year, 9 MA plans successfully launched disease-specific programs combined with enhanced benefits to help people manage their chronic diseases. Responding to interest from MA plans in other states, CMS added 3 more states to the demo starting next year. So due to the VBID success in the private sector, the TRICARE pilot, and nationwide interest in the MA VBID model test, bicameral, bipartisan legislation has recently been introduced to allow MA plans in all 50 states the flexibility to allow MA plans to set beneficiary cost-sharing levels on clinical value, not price, of medical services. It is my hope that the subcommittee supports the national expansion of VBID and MA, which when coupled with other promising integrated models like the PACE program discussed today, could result in healthier Medicare population, which motivates me as a physician, and more efficient federal expenditures, thus serving the best interests of American taxpayers and future beneficiaries. When Medicare was introduced in 1965, one of the foundations was this non-discrimination clause that every American in Medicare have the same benefit design. And as all clinicians and like Representative Black know, that medicine is unbelievably personalized and moving rapidly in that direction, down to the level of the gene. So we have argued that people should be treated differently and given access to different care, most notably an eye exam, which should be more easily assessed by someone with diabetes than someone who doesn't. There is a new initiative called the Choosing Wisely program, which has launched over 40 clinical specialty societies, naming specific services that maybe we're doing too often and spending too much money on. So broader spectrum of services, more flexibility on the specific conditions, and start to pay attention to the fact that while the best part of the demo is making high-value services more accessible, to be fiscally responsible, we have to start thinking about clinically driven reduction of low-value care. We have studied the impact of increases in cost sharing, because that's what's largely happened in this country, and it comes as no surprise, and you don't need advanced degrees like my fellow panelists to know that if you make people pay more for something, they'll buy less of it, and poor people are impacted by higher prices than rich people are. So we have focused very, very much on those people with multiple chronic conditions and those who are economically vulnerable, and have basically tried to implore public and private payers, if you can't extend VBID principles to everyone, you should probably extend VBID principles and lower cost sharing to the people who would benefit the most, and those are the sickest individuals and those who do not have economic resources. We know that there are a lot of low-income Medicare beneficiaries who are either cutting their pills or taking them every other day, or not taking them as their doctor or nurse practitioner prescribed the way they do that. And there has been external influences like patient assistance programs and charity programs to help bridge that gap. It is our hope that if value-based insurance designs are put in place, whether it be for middle income or low income, that those services that are deemed to be highest value would have zero cost sharing. Most of the major reforms going on in American healthcare, and particularly in Medicare, are these supply side or provider-facing initiatives trying to get clinicians like myself to behave different and better. And I think we've made marginal success in this regard, moving in that direction. We have not done the same for the patient-focused side. We have continued into this kind of one-size-fits-all design. And I think for me, to think the end-all is to find a situation where clinicians, hospitals, SNPs, ACOs, whatever, are aligned completely with the patient. That imagine now, Mr. Kind, I am paid a bonus to get my patients with diabetes to the eye doctor.
Right.
And my patients are in a plan for which they can't afford the deductible to go to the eye doctor for that exam. So my view about alignment is not more of these granular issues. Imagine a situation which we are moving slowly in a bipartisan way toward, where both the providers and the patients are aligned over health, understanding that we have to be fiscally responsible in this regard. One of my favorite demos is the Pennsylvania Rural Health Model, which has been taken in a bipartisan way in that state. Again, many rural districts there to try to preserve and protect access to care for many of those individuals who live in those areas, but being fiscally responsible in that way. And this is largely at this early stage a way to deal with hospitals and clinicians there. And they're only just now thinking about how to better engage patients to get care locally when it's best for them, in that rare instance where they have to go to a center of excellence to go elsewhere. Yeah. But again, many of these conversations are driven by dollars. And I love your theme of the fact that we have to think about health. As the practice of medicine moves forward at a rapid pace, Star Wars, we have precision medicine, we have genetic medicine. The delivery system, in my opinion, is like the Flintstones, right? So the delivery system has not been able to catch up to the incredible science that we've had. So we have one of two choices. One is that we slow down the innovation in the Star Wars medicine, which I would not advise, or we continue to have conversations like we're having today and have experts like I have to my right to think about ideas that allow us to have the delivery system catch up to the precise example that you raise. The Kaiser Family Foundation has all this information, a lot of good information in the testimony and elsewhere to answer these types of points. I do believe strongly that particularly in the low-income folks that we talked about earlier, that something as low as $1 matters. So I have seen Medicare Advantage patients who are faced with $4 copays for drugs that everyone in the exam room knows will be meaningful changes, but you never want to be in the situation to either pay rent, buy food, or fill your prescription, which is why we argue for these types of things. But I want to make sure, since it's not all things for everyone. I would like to start with those conditions and those services for which there is no doubt that they should be prescribed and used in those situations, which is where the nuance comes in. In some commercial settings, we have gone beyond free, and we have actually paid people to do certain things like quit smoking or take their prenatal vitamins or other types of things.
And we've seen a positive change.
We do, but
right?
we also have what I call the frozen carrot, that if people are given an advantage in lower cost sharing to do certain things and they don't, they should also be accountable for that
They
behavior
get the
as well.
stick on that side.
So I call it a frozen carrot. I'd rather call it that.
frozen-
In a large commercial experiment, we offered Americans in really good insurance plans who had heart attacks their drugs to prevent their second heart attack at no cost to them. They only took them 50% of the time. So we need to go beyond financial incentives, particularly the carrot, as you described, communication, literacy, transportation, not just drug reductions and co-pays to
Okay.
make this work. They took it more often than when they had to pay for it, but still we have a long way to go.
Well, I appreciate